HIV in southern Indiana, Governor Mike Pence has authorized a limited needle exchange for IV drug users. It has some leaders questioning why Indiana doesn't allow such exchanges in other part of the state. To talk about it, we have Dr. Deepak Ariga, who is an assistant professor of medicine at Indiana University Northwest. Doctor, welcome to the show.
Thank you. It's a pleasure to be here, and thank you for inviting me to speak to your audience.
Certainly. So let's start with what's happening in southern Indiana. There was an outbreak of HIV down there, and it's been targeted at what looks like IV drug users. What happened down there?
Well, there always have and will be outbreaks of IV drug abuse, or other infections linked to IV drug abuse. And right now, when you look at the epidemic, it seems to be linked to an increased use of a medication called Opana. In the past, one of the drugs of choice is, well, there are many drugs or narcotics which come in tablet form, which can be broken up, crushed into powder form, liquefied and injected. However, recent changes in formulations of OxyContin, which is a commonly used drug, make it very hard to actually turn it into an injectable form. When you actually add water, it turns into almost like a jello-like goo. So now the drug of choice is something called Opana, or oxymorphine, which is actually commonly being distributed. And that seems to be one of the main factors linked to the current outbreak. So it's not just the drug, but also the social networks of drug users who are using this compound who are actually spreading HIV between themselves.
And it is fairly uncommon to have governors decide to open up this temporary needle exchange. This is something that it's been controversy around the country, though I'm not exactly certain why it's so controversial. But tell me how these needle exchanges work.
Right. That's an excellent question. I mean, firstly, let's take away the politics. If you look at the scientific consensus, whether it's from government studies, the CDC, the WHO, local health authorities, there have been multiple studies showing that needle exchange programs, they don't increase the rates of people starting IV drug use, but they have shown a significant, decrease in the rates of new HIV or hepatitis C infections. The whole idea is basically provide an IV drug user with, fresh, clean syringes and needles. And even though you're not addressing the root of the problem, at least you're trying to break the cycle of transmission. Now, I think one main argument has been that, when you provide, fresh needles and syringes, in a way you're like egging on the problem. However, we do know that, there are multiple benefits of having needle exchange programs. Firstly, because, IV drug users are stigmatized and criminalized, the more we disengage with them, we're more likely to drive them underground and hence, encourage the propagation of HIV and diseases. So, by involving them or engaging them in needle exchange programs is sometimes a first point of contact. So, for example, you have an IV drug user, you provide them with fresh needles and syringes, but besides providing them with, and people claim the main concern is you're giving them new paraphernalia, it's also a point which you can bring up a new discussion about, personal benefits like getting them to rehab, providing healthcare benefits, screening for diseases.
But what you're saying, there's scientific evidence that if you provide needles to somebody who's abusing drugs, heroin or whatever, they're not likely. You're not likely to increase the number of heroin users out there just because you're providing these needles to them.
People choose to use heroin or drugs because it's a personal choice. So just making them easily available would not be an incentive to start shooting up.
But these have been banned at the federal level. Is that correct?
Actually, most federally funded studies, they do, as well as actually government-sponsored studies, have shown that needle exchange programs are of value. Most of the problem seems to be in Congress, again, for, moral issues, plus, the way we framed our whole argument as the war on drugs. So we see drugs as a problem, not as a medical issue, but more of a moral or political, crusade to fight against.
So even though, let's say, the CDC, they think this would be a good idea, this would stop the transmission or at least slow the transmission of disease, there's no real federal funding for these.
No, because unfortunately Congress controls the purse strings.
And normally these would be illegal in Indiana as well.
They would be, yes.
So it's a major step that the governor has decided to do this in this one case down in Scott County.
It's a step in the right direction.
All right. So, but you've been critical of this in the fact that it's 30 days. They've given 30 days for this to work. Why is that a problem?
Well, it sounds like it's more of a pilot project, if anything, because after 30 days, people aren't going to magically stop injecting drugs or are going to change their, current behavior, because most of these behaviors are, if not lifelong, are rather indefinite unless, we find a way to break that cycle. So again, needle exchange programs are just part of the issue. But again, 30 days is, way too short.
And you've seen some criticism from lawmakers like Representative Charlie Brown of Gary saying this is great, they're doing this in Scott County, but the rates of transmission through drug use are much higher in places like Marion County, Indianapolis, or Lake County
Yes.
up here in northwest Indiana.
Right. I mean, like I said, we know about an outbreak in Scott County because, there's been, amazing detection from public health. But like I said, usually what you see is sometimes the tip of the iceberg. Plus, in Marion County, Lake County, these are heavily populated areas, close access to urban centers. They'll run along, drug trafficking routes, major expressways.
So could you be as definitive up here and say that if we had a needle exchange in Lake County, you would see the rate of hepatitis C, they would go down, HIV, that it would go down?
Right. Well, again, based on the evidence we have from multiple, not just local, national, international studies, I mean, the answer would be yes.
It would be yes.
Yes.
All right. So, I mean, what is the scientific consensus on this?
Well, the scientific consensus is universal that, again, there's always outliers, but, the vast majority of, doctors, scientists, epidemiologists, social workers agree that, this is probably the most cost-effective single way to break the cycle of transmission. Again, politicians like to look at economics and money. For example, a single syringe or needle might cost you between 10 cents to $1, whereas the price to treat someone with HIV is probably close to about $500,000 over a lifetime.
So what do you think they're going to learn in 30 days? The State Department of Health is down there with the command center. They've got people from the CDC down there looking at Scott County. After 30 days, what do you think they're going to find?
Well, 30 days is too little a time to actually see whether there's a statistical drop in the number of new infections. Because again, detecting infections depends on many things. Number one, patients actually approaching a doctor or having access to health care. So like I said, after 30 days, we stop the needle exchange, everybody moves away. But again, the incoming data to actually give an idea as to whether this worked or not will take, weeks, if not months, to see what the benefits are. And during that period when you've actually stopped supplying clean or fresh needles, there may be an uptick in the number of new cases.
And right now there have been, 106 cases reported down there in Scott County. That's what drove all this. There are probably more now, but that's just from a couple of days ago. Does it usually, you see that kind of a spread where someone with hepatitis or HIV, one person is IV drug user and you see an explosion from just one person?
Well, both hepatitis C and HIV, the most efficient way to spread these infections is through the blood-borne route. And so let's say you have a patient with both hepatitis C and HIV who shares a needle. So, when you look back at mathematical models, so the risk of, let's say we're sharing a needle right now. So if I give you my needle with hepatitis C, there's a 30% chance that you're going to pick it up. With HIV, it's about 3%.
Okay.
So you can imagine one person or spreading it to or sharing it with like 5 or 6 other people. So, the more people who are sharing those needles, over time there can be an exponential increase in people acquiring new infection.
So with hepatitis C, it's like almost a 1 in 3 chance.
It is, yes.
So it can spread very rapidly.
Yes.
All right. Well, unfortunately, that's where we're going to have to leave it, at least for right now. This has been Dr. Deepak Ariga. He's an assistant professor of medicine at Indiana University Northwest. Doctor, thank you so much for being on.
Thank you very much.